Oh.
So what I've done is in the past, I just sort of poll the audience if there's any specific cases or questions or thoughts that people had about stuff that's happened over the last weeks or months that want a little bit more discussion about, from specific lesions or silly things that we're doing for interpretations. Anybody have any burning questions? You have to turn the microphone up. They're talking.
I mean, they'll hear.
Are they talking too much? Here, let's pan the audience here. Say good morning, everybody.
Really?
Hopefully the camera's not working.
No, it is working, actually.
I always have something good that happens. They can think of it.
Excellent.
What about the pseudoaneurysm that showed up on?
Mr. Coolidge?
Mm-hmm.
So that's a pretty rare finding, so that, I don't know if the camera heard that, but the question was about the left ventricular pseudoaneurysm that showed up on one of our patients. An aneurysm is basically an outpouching of some vessel chamber or cardiac chamber. True aneurysms were actually, there's a complete breach in the structure of the vessel or the pouch that there's an outpouching from, so that there's a dehiscence from the internal and anterior wall, so you actually have blood going in between the wall and causing the aneurysm to come out. The pseudoaneurysm is just mostly a weakness in the whole depth of the wall, meaning it's the whole, every portion or every structure of that wall just sort of gets weakened and outpouches out. There's not actually a defect between the wall tissues themselves. But this little boy was a transposition of the great arteries, had a little bumpy course in the cath lab prior to getting his balloon atrial septostomy, and then had a good operative repair with the arterial switch. Went home without any issues and was seen an outpatient, I think just 3 or 4 days after follow-up, and their outpatient cardiologist noticed that there seemed to be a little outpouching or a little structure there that she wasn't able to identify as being normal. And basically what she saw, if you're looking at the heart, the left ventricle with the apex down here just sort of pumping like this, off to the lateral sides of the patient's left, she just saw this little circle with blood going in and out that was outpouching off the lateral side of the left ventricle, which she described as either aneurysm or a pseudoaneurysm. In hindsight, when we look back at our discharge echo, every patient gets surgery here, please, with an echo sort of close to their day of discharge, if you sort of used the retrospective scope and looked at some of the images, you could say, oh, maybe there is a little, didsal beginnings of something abnormal here. But that being seen, she sent the kiddo back here. We got our own echo images and sort of confirmed what the outside cardiologist had seen. And it truly was, it looked like an appearance that the left ventricle had a weakness in it, and there was an outpouching, just about a ½ centimeter by a ½ centimeter in a 3-dimensional space, so just a little beam there coming off of the left ventricle with flow going in and out. So, once you diagnose that, the question then becomes, how the heck did this thing happen, and what do you do about it? How things happen, it's a pretty real darn rare thing to see, especially coming off the left ventricle, to see any type of aneurysmal formation or pseudoaneurysm. There's certainly reports of pseudoaneurysms or aneurysms from the right ventricle or the right atrium. These are not terribly uncommonly seen fetally. It's been reported in case series. Actually, I think my wife actually did a case series on either right ventricular or right atrial aneurysms that you can see fetally. But you do see them a lot in that sort of lower pressure system. And more times than not, in those patients, they end up just regressing on their own. They sort of go away. Although I do think in the last few months we did have that young girl who presented with a right atrial aneurysm with lots of arrhythmia problems. So anytime you have anything going on with distension or enlargement of any types of your cardiac chambers, especially the atria, you could surely have sort of an irritation to the conduction system of electrical pathways and cause some rhythm problems. So that girl came in with what we call a giant right atrial aneurysm, where just the right atrium just sort of ballooned out. She had that sort of plicated down. I think Dr. Jenna came in, sliced it down, took off the extra tissue, sewed things back up. And then the right ventricle ones usually go away on their own, probably mostly because it's a low pressure system. There's not a lot of driving force on the right side of the heart because the pulmonary artery pressure is a lot lower. So it's not going to push a lot more blood into that outpouching. But still, a very rare entity. When you go to the left side, I don't think we really have a good understanding of the mechanism of how this occurred. I think most of us were contemplating some sort of surgical injury would be the easiest thing to explain it, since the kid wasn't born with it, had surgery, then showed up post-operatively with this aneurysm. So one could propose that there was an injury to the muscle that weakened it, allowing that outpouching. So was there a retractor in the wrong spot? Was there, a bleeding vessel the surgeons had to stitch? Was there, the surgeons, when they measure the pressures, when they come back post-operatively and say the RV pressure is this, the LV pressure is this, that's done by just sticking needles right through the muscle and measuring the pressure inside those chambers. So this is in no place that they ever would have stuck a needle, but something you could have considered. The patient also did have a bumpy course in the cath lab, so one could hypothesize that maybe the catheter had gone amiss, started poking on a wall and weakened it, and we just didn't see it show itself until weeks after. And then the other thought would be that maybe the muscle in that area was weakened because it wasn't getting enough nutrition, it wasn't getting enough oxygen, there was some ischemia going on, so maybe the coronary flow to that portion of the heart was disturbed, so that during recovery, that muscle was just ischemic and weakened, sort of like a myocardial infarction. And so you cause an outpouching there. And that's probably the other sort of entity where you do see these aneurysms is in adults that do have MIs. You can certainly get apical infarct. You can surely get aneurysmal formations there, and pseudoaneurysms as well as in the left ventricle free wall. So ischemia is probably the most likely thought that this occurred. It's just unknown to why. Surely, as we do the arterial switch operation, we do have to play with the coronaries and not only switch them, we have to switch them back to the oxygenated blood as well after we switch the aorta and the pulmonary arteries. So there is some manipulation of the coronaries. They're definitely at risk for having stenosis or narrowing. They're at risk for clot formation that go distally, or air embolus could cause it. So those are sort of the thoughts and process that we went through thinking about how that little man get this big old aneurysm popping out there. Then the question is, what do you do about it? The risks are probably unknown because it's so rare, so it's really hard to say what the risk of this is, but at least the theoretical risks are you could have it get a lot bigger. Theoretically, I guess it could actually puncture. You could have significant bleeding, but that'd probably be the most rare complication or risk with this type of aneurysmal formation. Probably one of the other ones would be a problem with the conduction system, so it could cause some ventricular ectopy or ventricular arrhythmias if it got big enough. Probably the thing that scares us the most is clot formation, especially since it's on the left side of the heart. So if you have any clots form in the left ventricle or in this little outpouch in the left ventricle, and that clot goes out your aorta to your brain, stroke, out your coronary arteries, myocardial infarction, heart attack, and all those other bad things. So thrombosis and clot formation are probably our biggest concerns. His had a lot of flow back and forth, so it was sort of blood going switching right back and forth. So the risk of clot formation was probably lower in that situation because clots like to form when there's stagnant blood, or blood's not moving very fast. But it was still a concern that thing narrowed down a little bit. There was more stagnant blood. You got a clot form. The kid hiccups. The clot goes out. It goes somewhere really bad. You could be concerned. So the initial approach with him was, we know there's these theoretical risks, but on serial echocardiographic evaluation, at least here, there was no enlargement of the aneurysm. Still had to and fro flow, so we thought, probably just some aspirin or some other anticoagulation would probably be sufficient to keep him relatively safe, and then just sort of watch it. And most of that was from the surgical perspective. Jenna was looking at the images and looking at where it was. It was basically sitting on the bottom of the heart, coming off the sort of bottom side, so way back posterior. She didn't know how easy it would be to get at, and how she'd be able to fix it easily, especially in a child who just had surgery within the last 6 weeks, where there's lots of scar tissue. be lots of dissection that she would have to do. Wasn't sure that the risks initially would outweigh the benefits of closing a hole like that. But then the child returned to his outpatient cardiologist, and she thought maybe it was a little bit bigger, but it was probably about the same, but also began having a little bit more activity, and some more signs that it was being more irritative to the myocardium. So I think she went in, and I don't know when she did, probably last week or something, right now.
4 days ago.
4 days ago. I saw that there was an operative note there, and
So we did repair it then?
so she did. She went in, and I think she was able to find it and sort of ligate off the aneurysmal neck to prevent the flow from going in and out. Not sure if she actually resected it or not. Anybody know? So you have a little outpouching coming off the heart. You can find the neck of that and just basically put a suture in there and just, okay, blood can't get in, and just leave that little bleb of muscle sitting there, and it will if it doesn't have enough blood supply, it might just necrose off, just like you do with like a skin tag. Somebody might have a skin tag and just sort of put a little noose around it and let it necrose off itself. Or she could actually ligate it and actually divide it. I'm not sure what she did. There would obviously more bleeding risk if you do that. But if it was easy enough and had an obvious stalk, then she might have done that. But I think that probably should take care of it. Recurrence, who really knows for sure? This is such a rare thing. Hopefully this is an isolated area of weakness, hopefully caused by ischemia, and that it's not going to continue on, so hopefully you won't have a recurrence of that. And eventually go and be a little post-operative switch kiddo and do very well. Man, that was a lot of talking.
At what ages will you do follow-ups?
For the aneurysmal aspect of things, for him, I think he'd probably be getting, at this point, every 2 weeks or so, he'd probably get some follow-up echocardiograms, especially because of his age. It's easy to do in an infant. You don't need sedation to do an echo, somebody his age, just to make sure things don't reoccur. And we did see it sort of show up in the first weeks of life associated with his cath lab trip and his OR. So I think that he'll probably surely get one before discharge, probably a week after discharge, and start spreading them out to make sure things aren't forming back. But yeah, it's not something we see every day. I'm sure we've seen a handful in the last 5 years of different types of aneurysms. The ones off the LV without any obvious known injury are very, very rare, very interesting. But I do think this is probably from some weakness to the muscle and probably from an ischemic event, more than direct injury from surgery or from the cath lab just because of its position. Most of the other aneurysms, like I said, on the right side, the giant atrial aneurysms or the right ventricular aneurysms, usually are relatively asymptomatic unless you have arrhythmias. There's been very limited reports of any major side effects like clots or things like that have caused people trouble. So there's sort of a gray area of what you do. Do you need to do anything at all, or should you just watch these things? But he had enough anxiety and lots of different people to go ahead and take care of him. Any other questions about that?
No,
Anything else? A lot of talking, but only 10 minutes. Everybody get a donut?
Gabe, can you talk about valve replacements in adults at all, and the different ways you can replace them, and why you choose to do it one way versus another?
So I just talked 10 minutes about aneurysms, but that's a big, huge talk. But we can talk a little bit about valve replacements. Any specific valve?
No.
No valve.
Whatever valve you want to talk about.
Who was originally that had all 4 right?
Yeah, as an adult, they had all 4 replaced.
Yeah, all 4 worked on.
Oh,
Yeah.
Right, not replaced.
2 replaced and 2
That's still a
repaired.
lot though.
Mhm.
That's a lot.
Yeah, I mean, so there's obviously lots of different reasons why we replace valves. Either they're too narrow, they're too leaky, and the indications for those can be discussed at various times. But we can surely discuss some of the reasons why we do certain types of valve replacements or what options are available to us, and why we make those decisions. The common valves that we're, as we just mentioned, some gentlemen had all 4 valves, but aortic pulmonary mitral tricuspid, they all have sort of different idiosyncrasies of when you like to do things and what type of valve you like to do for those things. And a lot of the differentiation becomes to, do you want a bioprosthetic valve, so a valve that comes from an animal, which is actual tissue, or do you want to proceed with a mechanical valve, which is made from metal? And then there's some other options that we can talk about, such as the melody valve that we see coming through, and other things. I think that's the biggest differentiation, is why we do certain valves, mechanical versus bioprosthetic. If we take an aortic valve, for instance, and say a patient has a very leaky aortic valve, which is putting a lot of extra volume load on the left ventricle, dilating the left ventricle up because it's got extra volume, and the function's starting to get decreased. It's time for a valve replacement. And there's really 3 different options you can do to replace an aortic valve. One would be take out that valve and put in a mechanical valve. So just put in a valve that's made of metal. Advantages of a mechanical valve is that it's very durable. Usually could last decades with appropriate anticoagulation. There's a lot of different sizes that you could choose from for adults. Kids, we can somewhat get limited because we don't have valves that come down in the size of lots of our infants or even young children, so that's not always an option for us. But in adults, you have sort of an unlimited box, things on the shelf that you can put in for most adults. And they're surgically they're easy to place. So those are the advantages, really longevity, durability, size selection. The disadvantages I already mentioned would be one would be anticoagulation. Obviously, putting in a mechanical valve is going to be very prone to thrombosis formation. If you get any clot in that valve, and then the patients go to the dentist, or they have any chance for bacteremia, it's also very prone to endocarditis infection. Because it's metal, it's not getting perfusion from any blood vessels. It's really hard to treat any types of infection or clots on valves because you just can't send drugs to them because they're not being perfused in the normal way that tissue would be. There's no capillary bed. So patients have to go on lifelong anticoagulation, which usually be Coumadin at this point, some sort of heparin or warfarin combination. And so there's some risks and benefits of that. For instance, if you're a 87-year-old gentleman who's had 3 strokes and is walking on a cane, being Coumadinized might not be the best thing. If you're a 25-year-old firefighter who is doing lots of physical activity and falling off staircases and so forth, Coumadinization might not be the best thing to do. And then if you're a woman and you want to have kids, don't necessarily want to be anticoagulated in pregnancy with Coumadin. You can be, but it causes different issues as you're going through pregnancy. So those are the main downsides to that. Surgically, there's surely lots of things that we've seen up here as far as how valves are accepted in some of our patients, or how they tolerate the postoperative or the surgery itself and the postoperative course. A mechanical valve itself shouldn't really increase any risks of anything from a bioprosthetic valve. But a lot of times these patients, the reasons they're going for valve replacement have different comorbidities or clinical situations that make them sicker than others. The bioprosthetic valves are usually made from usually a pig valve. The pros and cons of those are, for adults, you can probably find most sizes you want to get into most aortic valve annuluses. And they don't require anticoagulation, so they're valves that are tissue, so you don't have to put patients on Coumadin for long term. So these are valves that we would choose for a woman that want to go through pregnancy. These are valves that we choose for some very active younger folks who don't want to deal with the risk of bleeding from physical activity or physical injury. The big downside for the bioprosthetic valves is that they don't last as long. So you almost have a 100% reintervention rate when you put one of these in. You know that within probably a decade or so, you're going to have to go back and do another open heart surgery. And even though we do hundreds of surgeries a year, every time you go into the chest and go on bypass, it's a cumulative risk for those patients. So that's probably the biggest downside. Why they don't last as long is sort sort of multiple fold. One, they can get calcified, and they can get, when they get calcified, they can get stiff and they get narrow, so aortic stenosis or valve replaced stenosis could be a reason to have to go back. The leaflets just might not be able to keep their integrity, so they get floppy and loose, so you get aortic insufficiency. You have to go back and operate. In younger folks, especially like adolescent patients and our kids that are sort of growing, the hormonal changes and going through their growth spurts, the bioprosthetic valves might even be a worse choice because we do see them actually get calcified very quickly. Sometimes we put valves in kiddos, adolescents that are gone in a year or two. So you only get a year or two out of a valve, and then you have to go back and replace it. Not always the optimal situation if they go through surgery in a couple of years. So mechanical aortic valves, long-lasting, durable, but you have to anticoagulate. Bioprosthetics, duration is sort of unknown, but surely a lot less than a mechanical. Don't have to anticoagulate. The third option for an aortic valve would be the Ross procedure. It truly is a valve replacement, and that's where we basically take the pulmonary aortic valve and put that in the aortic position. So we're sort of stealing from the pulmonary valve and say, okay, we're not going to give you a pig valve, we're not going to give you a mechanical valve, we're going to give you your own pulmonary valve, and we'll put it in your aortic position because we think the aorta is more important. So we put that in there, and then instead of a pulmonary valve, then we can put a conduit from your right ventricle to your pulmonary artery. So now you've got rid of aortic stenosis or aortic regurgitation. You put in a pulmonary valve in that aortic position, and now you have a conduit. That was sort of that was hot, a decade and a half ago. It's sort of a new surgery for aortic replacement. It obviously demands, again, 100% reintervention rate because you have a conduit there, and we all see conduit exchanges all the time. Now we can do different things in the cath lab, but we surely have to address those conduits after many years. And we found that the pulmonary valve in that position actually does a pretty competent job, doesn't get too leaky or too stenotic. But for whatever reason, especially in adults that have Ross procedures, we do see a pretty good incidence of aortic root dilatation. So their aortic root would have sort of dilate up after years after the Ross, which would then lead to neo-AI or pulmonary artery. The pulmonary valve in the aortic position will then become incompetent, get insufficiency. So they usually have those intervened upon. But those would be the three sort of main aortic valve things that you'll see our adult patients coming through. The patients you'll see doing this are just patients that have a bicuspid aortic valve that over years become more calcified and stenotic and insufficient. They need to have aortic valves replaced. Could be our little kids that were born with a critical aortic stenosis and had to have balloon valvuloplasties in the cath lab or even in the OR, and now they've sort of grew and progressed or developed through to a point that now they need intervention upon. And some, lots of other more complex types of heart disease. Obviously, we try to stay away from any. We hate to replace valves in any of our single ventricle kiddos, but surely we have to do it times. I mentioned the Melody valve just briefly, and that's most of you guys have seen basically a valve that we can put in the cath lab, just with big, huge catheters in the groin or into the neck. We can actually deliver a valve that basically gets scrunched up into a catheter sheath, and you can just put that valve, and then you blow it up in whatever orifice you want to blow it up in. Right now, it's approved for basically putting as a pulmonary valve, so you can't really do it in any other position unless you get compassionate care exemption from your internal review board, which we've done a few interesting placements here. But it is certainly a nice valve that you can use for the appropriate patients. And the patients have to be appropriate in the sense that they have to, at this point, still have a conduit. So they have to have a RV or PA conduit that's been in place from a previous surgery, so that valve can then sit in the conduit and sort of make a nice competent valve. And the conduit has to be a certain size. So kiddos that have a 12mm conduit put in when they're infants, now that conduit is stenotic. They're just not. We just don't have valves that small yet that we can put in, that we can intervene in the cath lab. But adults that have a stenotic conduit or a leaky conduit and they need a valve replacement, we can just go through the vessels in the groin. Usually put some stents to sort of make that conduit nice and firm and distend it up as much as we want. We can put a valve in there just percutaneously, and it's usually, you know, an overnight stay admission at most, which makes it very nice for lots of our patients, especially if they have risk factors for having big open heart surgery or being on cardiopulmonary bypass. But again, it's only indicated for the right side right now, so that we put one in the tricuspid valve position, put the melody valve in the tricuspid valve position, but most times it's right now approved for RV and PA conduits. In Europe, it's being used for anybody who's had who needs a pulmonary valve that's had tent repair, so somebody who's had a transannular patch. You know, usually pulmonary insufficiency gets handled very well for many decades of life, but it's when you become older that right ventricle then gets bigger and bigger and bigger and bigger, and we start seeing problems with failure and other types of problems with induction systems, that we're recommending valve replacement a little bit earlier. And again, in Europe, they're starting to do it in patients that have had transannular patches and don't have conduits. They're basically developing a valve that's more contoured to the individual patient that can just sort of fit in whatever space is there and replace valves that way. So that the percutaneous method is going to become more and more prevalent as we see it, which I think is going to help a lot of the patients that are at risk for having big surgeries. So that's a lot about sort of aortic valves, Ross, a little bit about melody valves. When you start talking about pulmonary valve positions, usually we try to put bioprosthetic valves in there. Because of the lower flow and lower pressure state of the right side of the heart, there's been historical evidence that putting mechanical valves in the pulmonary valve position can lead to more thrombosis than the aortic valves. So usually we try to put bioprosthetic valves and they last a little bit longer there. They're just not dealing with as much pressure load and volume load, so hopefully they will be tolerated more. Mitral valves for mitral stenosis or mitral regurgitation. You can certainly try to repair those. As a gentleman with 4 valves, the gentleman with 4 valves had a mechanical aortic valve, bioprosthetic pulmonary valve, and then repairs of both the tricuspid and mitral valve. So they either try to repair some of the commissures of the leaflets, make sure they're opening and closing appropriately. It's a big dilated ventricle, and the valve leaflets are getting pulled apart, and that's why the blood is going backwards. You can basically try to put a ring around the annulus and bring everything back together, which is what this gentleman had. To sort of pull back all the leaflets and pull everything together so that they remain competent. And sometimes you have to replace it. A lot of times, because most of the flow is going through the mitral valve, all of it diastole. It's a lower flow state than through the aortic valve, which is systole. So big jets of blood going out your aortic valve, but the mitral valve is sort of slow, passive blood moving. We like to avoid mechanical valves for that position because we talked about before, stagnant blood causes clots. So the slower the blood's moving, the more chance you're going to have clots. So if we can repair a valve, we'd rather, and that's why a lot of times our folks that are down in the OR will have mitral valve repair or replacement listed on the OR sheet, because they'll always try to repair first, see how it looks with post-operative TE or something, and then if they have a good repair, they'd rather leave you with a little bit of insufficiency or stenosis than have to put a mechanical valve in there. Because a mechanical valve is really the only true validated approach to replace a valve at that bit in the mitral position is putting in a mechanical valve, and then making sure that your anticoagulation is even better than the aorta, again, just because of the low flow state. We actually shoot for higher INRs, higher anticoagulation than the mitral valve, than when you have a mechanical valve there versus an aortic valve. And they're more prone to thrombosis and more prone to having problems. Probably replacing the mitral valve is a bigger surgery than the aortic valve. You're deeper into the heart, you're dealing with the internal heart structures as opposed to just the outflow tract. And there's more concerns with the conduction system. So the bundles or the conduction system runs right back by the annulus of the mitral valve. So anytime you're sticking big old pieces of metal rings in there, pushing things, you can surely cause trouble with the conduction system. We've had just a few people in the last few weeks that have had mitral valve work or mitral valve replacements who all now have pacemakers as well. So that's definitely one of the big risks there.
Is it pretty common?
Yeah. I mean, it depends on what the other surgical history of the patient is. The patients that have had other surgeries and have a right bundle branch block, these big sort of wide QRS complexes on their EKG tracing, that means the right bundle or the tree going to the right side of the conduction system's already been damaged. Well, the left side system is what runs right by the mitral valve. So if you happen to get that when you replace the mitral valve, there you go, you got a heart block. So it's not terribly uncommon, especially in our younger folks, our kids who need it replaced. Again, it's a size issue. There's not as many sizes off the shelf. Sometimes we have to squeeze. Even the smallest size we get off the shelf is still a squeeze to get in there, and so we're pushing on structures and sort of, getting a wedge and a crowbar and sticking them in there. And they can compress either a conduction system, they can actually compress coronaries, and they can compress other things that can cause, conduction system abnormalities. And it's just, it's a big surgery too. They have to really get a lot of exposure. They have to keep the heart paralyzed for a while. They may or may not have to do circulatory arrest depending on how they're able to perfuse the aorta. So the people that have had 4 valve surgeries or 2 valve surgeries, I think our most common thing is aortic valve and mitral valve. It's sort of the Owens complex patients that have sort of underdeveloped left-sided structures where eventually they need replacements in the aortic and the mitral. And the combination of doing both those valves at the same time can be tremendously stressful surgery. The adult data would suggest that the 5 or 10 year mortality was 50% after a bi-valve replacement of aortic and mitral, but they're adults, their ages are higher, so your 5 to 10 year survival of somebody who's 65 is different than your 5 to 10 year survival of somebody who's 18. So, but it's a high morbidity, high mortality surgery, and we've certainly seen our share over the last 10 years of younger teenagers or young adults need sort of aortic and mitral valve repairs or replacements who've been very sick post-operatively and had some difficult outcomes for sure.
Yeah.
Tricuspid valve, just real quickly, usually same thing with the pulmonary valve.